Okay, this is the Psych Commute with me, Dr. Brown. I am an inpatient psychiatrist in Houston, and I am currently driving home from work. Today was an eventful day. Had to send someone to the ED for chest pain and shortness of breath, but that is not what I'm talking about today. Talking about something much less exciting, and that is how I do my notes, how I do my clinical documentation. So I do my notes backward. I do them not in the typical SOAP format, subjective, objective, assessment, and plan, but I do it assessment and plan, and then data. And so it's basically APSO. This format is, I think, a bit common, or at least not uncommon, in internal medicine and perhaps some other non-psychiatry specialties, but seems to be pretty rare in psychiatry. And in fact, sometimes when one of my colleagues is covering for me, they will copy forward my note and rearrange it so it's back into the normal sub format. So apparently it's either misunderstood or loathed. So I want to explain why. So first, just to go into a little bit more of the structure of how I write my notes. So at the very top, I will have the patient's reason for admission. And again, this is for inpatient psychiatry. I will have the reason for admission, and that'll be, John Doe is a 56-year-old male with a history of schizophrenia and hypertension who was admitted for an acute exacerbation of psychosis in the setting of medication non-adherence, something like that. And then I'm going to have a running hospital course. So I basically put the date or something like hospital day 1 or day 2 or whatever, and I update that every day. And that's because I will use that to make my discharge summary. Because now in the Epic EMR I use, there is a built-in AI tool that can summarize text. And so I just copy my running hospital course into the discharge summary and use that AI tool to turn it into a kind of prose form, paragraph form hospital course. So every day I will usually just write 1 or 2 sentences in that running hospital course. So for example, on day 1 of the hospital, I might say admitted for psychosis, started on risperidone 1 milligram BID and amlodipine 5 milligrams for hypertension. And then day 2, patient continues to be disorganized and reporting auditory hallucinations. So risperidone was increased to 1 plus 2 milligrams, something like that. And then I will go into a problem-based plan. So usually I structure this where I have the little hash symbol or pound symbol, and I'll say pound auditory hallucinations. That's the problem. Sometimes there's multiple problems that I'll cluster together, like auditory hallucinations and disorganized thoughts. And then I'll put below that the working diagnosis. So working diagnosis, schizophrenia. So in the example I'm giving, this seems to be pretty consistent with their past diagnosis of schizophrenia. Then I'll just leave it at working diagnosis. But if it's more of an undifferentiated problem, like patient is admitted for erratic behavior in the community, brought in by police, something like that, then, to me, that's an undifferentiated problem. And so I will still use the same structure. So I'll say problem is erratic behavior, and then the working diagnosis might be psychosis unspecified. And then below that, I'll have a differential diagnosis, and that might be substance-induced psychotic disorder or schizophrenia, or schizoaffective disorder, acute mania, encephalopathy, whatever, right? And then below that, I will have any workup that needs to be done. So labs, studies, whatever. And then I will have their treatments. So risperidone 1 milligram BID is going to be there. And then I will do the same for any other problems. And if it's a chronic problem or a well-established problem, it's not a undifferentiated problem, then I'm not going to put all that working diagnosis and differential diagnosis and all that sort of stuff. For example, if someone has hypertension, the problem will be hypertension, and then I'll just have a little bullet point that says amlodipine 5. So it's much simpler. So the primary psychiatric problem is a little bit more detailed, and then the rest of the problems are usually simpler. Now, if it's a really complex patient, then under the problem, instead of just having a working diagnosis and a differential, I might have some prose text to just more clearly document my clinical reasoning for liability purposes. And also if it's just a complicated issue where if someone's reading the note, they're not going to be able to fully get the situation. But in general, I'm not writing a full assessment paragraph like a lot of people do in psychiatry. So I make sure to list out all the problems that I am treating, including all the medical problems. I also have a problem for risk assessment and mitigation, and that'll include things like suicide precautions or fall precautions or anything else that is a risk factor that I need to pay attention to or address. And then I have a discharge planning problem. And that's where I will, even from day one, I'm thinking about discharge. Where are they going to go? Are they going back to a shelter? Are they going back to a group home? Do we need to think about making a referral to a substance use program? So on and so forth. And then after I've got all my problems listed there, I will have a data section. And that includes the subjective, because to me, what the patient tells me is just data. And that just informs the overall synthesis of the data together with the objective data. So I'll put the subjective information there, and then I will have the objective data, so the labs, the mental status exam, physical exam, and all that stuff at the bottom for me. And it also kind of reflects how I'm thinking about the patient, because when I'm starting with the assessment and plan, it also helps me kind of hone what I'm putting in the subjective, because the patients may tell me a lot of things that's just irrelevant. But when I start with the assessment and plan, that kind of helps me filter out the irrelevant stuff. And then the other thing that I think is helpful about doing it backwards is that usually when I'm writing my notes, I struggle to stay focused. And so, especially when I'm doing a bunch of notes at the same time, it helps me to do the most important thing first. Reminds me to do any order updates and things like that that I might have missed. And so by doing the assessment and plan first, it just get the important stuff out of the way, and the rest is just kind of filling in some data. And for me, that just helps me get through the note faster. So anyways, that's why I do my notes backwards. And so maybe I will convince someone out there to start writing their notes backward too.